I think we're straight up noon. So I know we have a lot of fantastic information to cover today. We'll sure have folks joining as we get introductions and get started. But I'm Evelyn Nelson. I lead our Heartland Telehealth Resource Center and so glad to have everyone join us today. Um, Today we'll be touching upon telehealth billing, coding, and policy. Just a few reminders. This session's being recorded and we'll be able to share that with you afterwards. Your microphones have been muted, but please do unmute or use the chat. We'd love to hear from you and love to have your questions and comments. Your completion certificates will be emailed. We really appreciate if you can sign in with your first and last name so we can identify you, so we can get the certificates out to you as quick as we can. So with no further ado, let's get rolling. It's really my pleasure to introduce Rochelle. I know for many of you, she's a familiar face and has been a fantastic resource for us throughout the pandemic and now looking beyond. She's a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. So, Rochelle, please take it away. We're so eager to hear what you have to share today.
Thank you. Thank you so much. This is one of my favorite times of the year when the Medicare physician fee schedule is announced. This year was over 2,000 pages, but it's just full of so much information, not only what we can see in terms of changes in coding and payment and policy for the upcoming year, but it gives so much insight into what the agency is doing and their rationale and their thought processes that I think it really sheds light on a lot of things that are going on in our environment and certainly some major changes that are coming up effective January 1 of 2023. So in those 2,000 pages, I've tried to break down kind of 4 key areas with respect to telehealth that have some changes or some guidance that I think would be really helpful for this group. Each of these has a lot of subcomponents to it. So we could certainly spend a lot longer than 1 hour going through all of the details and nuances, but I'll start with kind of going through some changes to evaluation and management codes from the code book itself. What we saw from actually just a week before the Medicare physician fee schedule proposed rule was released, there was a big announcement from the American Medical Association, which keeps the CPT code set. And American Medical Association announced some changes that are happening to evaluation and management codes within the code book. Deletion of codes, merger of categories of codes, and I'll talk about some of those today. As well as changing the guidelines that tell us when is a patient a new patient versus an established patient. What do we do when we have providers covering for other healthcare professionals? How nurse practitioners and physicians work together and how that impacts the codes that they ultimately get to report. These are some of the most substantial changes I have seen to the evaluation and management section of the codes in the code book in my career. So that coupled then with what CMS announced in the proposed rule, CMS is looking at some of those those changes that will go into effect January 1 of 2023 from the code book, and Medicare is describing what their policy or what their approach or response is going to be to those codes. Now that impacts telehealth because those are a lot of the codes that we end up assigning as the distant site professional rendering telehealth services. So we need to know about those changes and who gets to bill initial hospital care or what we classify as a new patient versus an established patient whenever we're providing those telehealth services. So we'll touch on some of the highlights and the key points. I've got a whole hour-long session that we can certainly share with HTRC just on that first bullet point on evaluation and management changes that are coming up. Remote monitoring continues to be a topic of discussion. What I was surprised that I didn't see in the proposed rule was interpretations or guidance on some of the gray areas of remote patient monitoring that have been causing providers a lot of questions. But what we did see is Medicare addressing the newer codes and reimbursement for remote therapeutic monitoring. And so we've got some guidance there and actually some changes in the codes that are going to be reported based on the type of professional that's rendering that remote therapeutic monitoring service. And just as a kind of stepping back a year or so, we've got two main categories of remote monitoring services. There's remote physiologic monitoring. You'll see that often abbreviated RPM. And that's for things like monitoring blood pressure, pulse ox, temperature, weight, the physiologic data, right? And a device that transmits that data electronically back to the provider. Those are evaluation and management codes. And there are certain disciplines, certain professionals and credentials whose scope of practice does not allow them to report evaluation and management services. So this second category called remote therapeutic monitoring, or RTM codes, were created, and they're designed to be a little bit more of subjective data, patient with increasing shortness of breath or activities of daily living or musculoskeletal functional status. They're in the medicine category of CPT, which opens the door to a wider range of healthcare professionals to report those services. So with that kind of very high level overview, we'll dig into what those changes to the RTM category are and why Medicare is making those. Then, of course, there's a whole section devoted just to telehealth codes and services that we'll talk about. What codes are going to be made permanent telehealth services versus temporary versus category 3, what the difference between temporary, and category 3 codes are, and just a reminder of what the wind down of some of these codes that have been added during the public health emergency is going to look like once we at some point wind down the public health emergency and enter into the post-COVID PHE environment, and what telehealth will look like at that point. And then finally, there are a couple of provisions for RHCs and FQHCs we're going to talk about. So just quickly before we dive into some of the specifics in the proposed rule, I thought the timing would be good as a quick refresher on where we are with the status of the federal public health emergency, the one that gives Medicare the flexibility to make a lot of these telehealth services available in the way we're currently providing them, expanding the scope of the types of telehealth services, the longer list of CPT codes that can qualify as telehealth, being able to render them as audio only telehealth services during the PHE, being able to render them to patients at home and outside of rural geographic or healthcare provider shortage areas, and so on. And additional healthcare professionals that are not typically eligible to provide distance site services. So most recently, CMS kept us waiting until what felt like the 11th hour, July 15th, and that day issued the notice that they were going to renew the PHE. So the renewal is for up to 90 days. As we've seen throughout the public health emergency, it has been allowed to go the full 90 days, and then it's renewed for an additional 90-day period. So we have it was about a year ago, July of 2021, the Secretary of Health and Human Services sent a letter to the state governors expressing an intent to notify the states or make an announcement 60 days before the public health emergency is going to either be revoked, because it can be revoked sooner than that 90-day period, or allowed to expire at the end of that 90-day period. So if we get that full 60-day notice, then it's possible here, we're already at almost to August, so within the next 2 weeks, that we could see an announcement like that if we get the full 60 days. Now, Robert, I don't know if Robert Stiles is on the line. He had shared with me earlier this week in some presentations with federal agencies in the last week or so, sort of an indication or a signaling that instead of 60 days, that advance notice may only be 30 days before the PHE is allowed to expire or is otherwise revoked. So if we have 30 days notice before the end of the current 90-day period, we'd kind of be watching the mid-September timeframe to see if we get any publication or announcement that it's going to end in October. If we go through this full 90-day period, then the end of our current 90-day period would be October 13th of 2022. So if we don't hear anything by mid-September, that may be signaling yet again another 90-day renewal into January of 2023. If you can believe we're almost 3 years into this by now. So those are some important dates coming up that we'll want to keep track of. If you want a copy of the current renewal or that letter to the governors from last summer, I've got a link to those here when we send the slides out that you can access those. So with that announcement and knowing that we are still in the public health emergency with no indication of when that may be allowed to expire or end, I'll dig into some of the kind of 4 key areas of the proposed rule for 2023. And quickly, I want to highlight a couple of things here. Right now, this is just a proposed rule. Often, a lot of the things that are in the proposed rule end up getting finalized in some form or another. They might be modified based on public comment, but we have an opportunity until, through September to submit comments, responses, questions, concerns with any of these proposals. So this is signaling where Medicare is planning on going, but it doesn't necessarily mean this is exactly what's going to be finalized. Whatever does get finalized will go into effect January 1 of 2023. One thing we do know with respect to evaluation and management services is that the rules from AMA in the code book that are going to change will go into effect January 1 of 2023. There's no comment period or period of review. Those have been announced and finalized. That's going into effect January 1. So that's a big date for us to keep in mind here. In the evaluation and management section, I mentioned these are some of the most significant changes I've seen. Several years ago, gosh, I say several years ago, it was probably 2008 or 2009, Medicare indicated they were no longer going to pay for consult codes. We had some changes in the last year or two to the way levels of service for office and outpatient visits were calculated. The changes that we see for 2023 within the CPT book that Medicare is by and large adopting really span all categories of evaluation and management services in the code book. So they are fairly significant. If you've been tracking what happened with the CPT codes for office and other outpatient services, 99201 through 99215, both new and established patients for 2021. There were some changes to the way we determine the level of service. So by level of service, I mean a very simple, straightforward issue would be coded as like a level 1, very complex, high complexity decision-making, comprehensive histories and exams, coded as level 5 visits. And in the past, there was this very complicated algorithm. This is a copy of the checklist of what this used to look like, right? And providers had to know in their head, I need 4 elements of HPI or the status of 3 chronic conditions, plus 10 or more review systems, plus past medical family social history. And there's 5 different ways to determine if the physical exam was expanded problem focused versus detailed. This complicated algorithm on history and exam and decision-making, this goes away. It went away for office and other outpatient visit categories in 2021. So we've been getting used to the codes in that category. What CPT did that Medicare is also following suit is expanding that idea of history elements, exam elements, is no longer going to be this complicated algorithm of checkboxes. All we're concerned about is one of 2 things for the majority of evaluation and management codes. How complex was the medical decision-making, and or what was the time spent during the visit? So this history exam piece, providers still need to document a clinically appropriate history and exam. This avoids the need to try to make sure you've got 4 elements of a history and present illness. Just document what's appropriate and what you think needs to be recorded for the patient's services and history and exam. What it also does is it means providers really need to understand the new medical decision-making table, which is different than what it used to be prior to 2021. And now, not only providers who operate in an office setting that report 99201 through 99215 need to know those rules, but all providers need to know the new table and matrix on how medical decision making is calculated. We could absolutely dive into that and probably spend a full hour just on that one piece, but that concept is being extended to the rest of the E&M section. The goal, hopefully, is to simplify it. One thing I'll add too, so I mentioned the new concept for how we report the level of office and outpatient visit, and soon in 2023, the way we determine the level of many other E&M codes as well is medical decision-making or time. So the other factor there, time, in order to assign a level based on time in the past, we used to have to document that greater than 50% of the encounter was spent in counseling and coordination of care, to use time as the driving factor. That is no longer the case under CPT rules or under Medicare rules. When we are assigning a level of service based on time, it's just the duration of the visit. And then the times for some of these codes have changed a little bit. So we also don't have to have that level of detail. Greater than 50% of the visit was spent in counseling coordination of care, with the duration. Simply saying it was a 40-minute visit or a 50-minute visit allows us to select the level of service based on time if that's appropriate. So here's where things start to get muddy and murky, if they weren't already. In the Medicare proposed fee schedule for 2023, Medicare is examining what the CPT book is doing for different definitions and different guidelines on when and how to assign codes. And CMS in some places is proposing to have a different policy and a different rule than what is being implemented, what has been finalized in the code book itself. So I kind of want to walk through some of those changes that we're seeing in the code book to make you aware of those, but also make you aware of the way it would be different under the Medicare program. So under CPT, this is going into effect. This is the definition that will be in the code book, right? So anybody that follows any payer that follows the CPT book definition, these are the rules that we would follow. The definition of a new patient: one who has not seen the provider or another provider of the exact same specialty and subspecialty in the same group practice in the last 3 years. That's been our definition of new patient for a long time in the CPT book. But what they clarified in the CPT book for January 1 of 23 is that nurse practitioners, physician assistants who are working in collaboration with physicians are considered to be in the same specialty as the physicians that they're working with. That's what's in the CPT book. CMS says something different, and I was kind of surprised with this guidance and this interpretation from CMS. I want to take a step back and talk about specialties and subspecialties with Medicare for a minute. When you enroll a provider with Medicare on their 855 enrollment form, you identify what specialty they are in. Medicare doesn't recognize subspecialties. So we're only looking at that first level. So for Medicare, a new patient is one who has not seen a provider of the same specialty in the same group practice, regardless of what the subspecialty is in the last 3 years. And when you enroll non-physician practitioners, like a physician assistant or a nurse practitioner, they have their own specialty taxonomy. So for example, a nurse practitioner, there's a 2-digit code, and I want to say it's 50, I might be wrong on that, that identifies that specialty of the enrolling provider. And when the nurse practitioner is working with, say, orthopedic surgery or internal medicine or a hospitalist, the hospitalist, the physician, they will identify their primary specialty, which is different than specialty 50 nurse practitioner in terms of Medicare enrollment. So Medicare says non-physician practitioners like a physician assistant or nurse practitioner are always considered practicing in a different specialty than the physicians that they work with. And I don't know that I've ever seen CMS explain it quite that way before. And the significance of that, if we think about the definition of a new patient, kind of look at the clinic setting. If the patient sees Dr. Smith, primary care provider on one day and is a new patient, and next month comes back and sees nurse practitioner Marting, those are different specialties. So the way Medicare is interpreting this is that the visit with the nurse practitioner would be a new patient visit. That patient has not seen a provider with that specialty, nurse practitioner, in that practice in the last 3 years. And that's a change. So that change, I think, in terms of our coders and our billing systems that have been configured, my impression for a long time, to impute the specialty of the physician onto the nurse practitioners and PAs that are working with them, is different for Medicare beginning January 1 of 2023. Now, Medicare says this has always been their policy. I have not had the time to research that because I can almost picture guidance from Medicare. I just don't know when or where I read it saying that they used to impute the specialty of the physician onto the non-physician practitioner. So I will certainly share that resource if I find it. But in the proposed rule, Medicare saying that's always been their policy in terms of non-physician practitioners having different specialties. All right, so moving on to initial visits. We've got in the office setting, we have the concept of new patient versus established patient. In facility settings, there's a concept of an initial visit where the idea is that you may have more work to do a more comprehensive initial encounter with the patient than maybe your subsequent hospital visits or your subsequent nursing facility visits. So there's been some change in the guidelines on what it means to be an initial visit and who gets to report a code for an initial visit in those facility settings. So under CPT, the current rule today, right now in 2022, is that only the attending provider can report an initial hospital care, initial observation, initial nursing facility visit. All other providers, even their first visit with the patient during that stay, are reported either with consult codes or with subsequent hospital, subsequent nursing facility codes. Now that's the CPT rule. That's what's in effect right now. Beginning 2023, the rule that will be in effect in the CPT book is that an initial code for the patient's admission can be reported once per specialty and subspecialty, per group practice, per admission. So if we have different subspecialties, CPT says both of those subspecialists could report an initial code for the visit.
And Rochelle, we do have a question
Yeah, sure.
in the chat that is tied to this, I believe. So they're wondering if cardiology and cardiovascular, if they have different taxonomy codes, then they could bill the new patient, even though they're under the same tax ID. So that to clarify, she wanting to know if it's based on taxonomy and not tax ID.
Okay, so the tax ID refers to the group practice and whether they're in the same group practice. So if they're billing under I'm envisioning the paper 1500 form, and at the very bottom, it's either box 32 or 33, where you identify the billing entity, the group practice. If those specialists are billing under the same tax ID, that makes them part of the same group practice. If they're not billing under the same tax ID, the whole specialty, subspecialty designation doesn't matter because they're not in the same group practice. If they are billing under the same tax ID, then the specialty and subspecialty taxonomy designations come into play to determine if we've got a new patient or established patient, or whether they can both report an initial visit code. So what I always do when I'm looking at providers in group practice who are working together, once I've figured out that they are in a group practice, I go to the CMS NPI registry. I look those providers up and I see what their specialty and subspecialty designations are. And if they have different subspecialty taxonomies with their NPI number, then that's a clue to me that under the CPT rules, they may both be able to report new patient visits, except for Medicare. They may both be able to report initial hospital care codes, except for Medicare. Kind of the second part of that is you would want to make sure that's the way they are credentialed with the insurance companies, in terms of your enrollment and your contracts with the payers.
Thanks, Rochelle.
Absolutely. Okay, so that's what's going to happen with CPT. Now let me switch gears and talk about what CMS is doing with respect to initial facility, initial admission codes. So right now, today, under Medicare's policy, if you go to the internet-only manual 100-04, it's the claims processing manual, chapter 12, Medicare discusses who gets to report initial hospital or initial nursing facility visits. And Medicare's current rule is that multiple providers could report an initial care code for their first visit with the patient, that admission. That's different than what you see CPT is proposing to do, or excuse me, what CPT has in effect now. Medicare is proposing that the new guideline would be similar to what CPT is doing, one initial care code per specialty, per group practice, per admission. That's a change for Medicare. That reduces the number of providers that can report an initial hospital care code or an initial nursing facility visit. And remember, because Medicare doesn't recognize subspecialties, we are looking at the specialty that is designated on their 855 enrollment form. And if they're billing within the same group practice, only one of them gets to report an initial visit code within that group practice, within that admission. Now I've got this in bold, the second to last bullet here, because this is an area where I'm hoping I can work with some groups to provide a question or clarification to Medicare, because this is not accurate based on Medicare's current manual. It says, we propose to retain our current billing policy that the provider must see the patient in the emergency department and then admit the patient and see the patient once they are admitted in order to bill an initial hospital care code. Right now, that's kind of Medicare's policy for an initial observation care code. That is not Medicare's policy for initial inpatient visits. If you go up to the top bullet on this slide, Medicare's current rule for inpatient visits, and I'll just read it from the manual so I don't botch the language. In the inpatient setting, all physicians who perform an initial evaluation may report an initial inpatient hospital care code. The attending adds a modifier to identify themselves as the attending. So this statement in the proposed rule that the current policy is only the provider who sees the patient in the ED and then writes an order for admission and then sees the patient as an inpatient is not an accurate reflection of what the current policy is. So I'm hoping I can raise that in comments or questions to the proposed rule. That would kind of sort of be consistent with what the current policy for initial observation care is. The current rule for initial observation care with Medicare is not quite what they're saying here. It's not so specific to say that the provider has to see the patient in the ED and then follow them into observation in order to be able to report an initial OBS code. But it does say that the provider who writes the order for observation admission and then sees the patient once they are in observation status, is the only one who can report an initial observation code under today's Medicare policy. But what I think we're going to see, oh yeah, go ahead,
We've
Krista.
got another question in the chat here. Where do hospitalists fit in with the billing process?
Absolutely. So these rules are going to apply whether that first visit with the patient is a hospitalist that's doing the H&P when they're admitted to the facility, whether it's orthopedic surgery, whether it's internal medicine, endocrinology. These rules are going to be across all specialties for both Medicare and for under the CPT rules.
Thank you.
Absolutely. One thing I'll add to this is that a huge change that's happening next year in the CPT book itself is that all of the codes that we currently use for observation care are deleted. The codes that we currently use for inpatient hospital services will be revised to simply be hospital services, regardless of whether the patient is an inpatient or an outpatient. So somehow, some way, Medicare's current rules on who gets to report an initial service will have to be reconciled because we're going to be using the same codes and try to figure out who gets to bill the initial code for those services. But I will just highlight that what's in the proposed rule, in my opinion, is not an accurate reflection of what the actual policy today says for those services. For prolonged service codes, we've talked about this in some of our previous sessions. The inpatient prolonged service code is deleted from the CPT book, and then there's going to be a new prolonged service code, essentially for 15 minutes or more beyond the time for the highest level hospital care code. The reason I think CPT is doing this is that they have different prolonged codes depending on whether the patient is an inpatient or an outpatient or observation. Well, that concept is going away. So they don't need inpatient prolonged service and observation or outpatient prolonged service codes anymore. This new code will simply be prolonged services in the hospital setting, 15 minutes or more. So for CMS, what they're proposing to do with that change is not recognizing the new CPT code for prolonged services in the hospital setting, and instead creating their own new G code. So it's not that they're not covering prolonged services, it would just be coded in a different way for Medicare using a different HCPCS code. And when we use that code for Medicare, it would be 15 minutes beyond the time for the primary service. Prolonged time could only be reported if you are selecting, if your base code is the highest level available. That's also a change from current coding rules. We don't have to use the highest level of service available to report a prolonged service. If we are basing our level of service on history exam and decision-making today, we could have a level 1, a rather straightforward visit that just took a really long time. Maybe explaining things to the patient or having a translator involved, some of those factors that may have taken longer to deliver that relatively straightforward service. So this is also representing a change that we would have to reach the highest complexity or highest duration code for the service in order to assign a prolonged service code in a hospital setting. We would not be able to bill what the codes that today represent non-face-to-face contact with the patient in the hospital setting. It's not that they're not, that it's not a covered service. It would just fall under this new G code that Medicare is creating rather than the CPT codes. Now, believe it or not, the reason for this proposal is Medicare thinks that would be much simpler than just recognizing the CPT code that's in the CPT book. Okay, one of the changes that has happened with a split and shared service, that's a service that's performed in part by a non-physician practitioner and a physician. In the CPT book, any service can be split or shared. An office visit could be in part performed by a nurse practitioner and a physician. A hospital visit could be performed by both. It's not limited to the site of service or the category of evaluation and management code. And CPT added a definition on what a split or shared service is. CPT does not define which of those providers gets to report the split or shared visit. Medicare has long had a policy on split and shared services that was removed or eliminated in May of, I'm going to get my years mixed up here, either 2020 or 2021, as part of good guidance regulations, where this policy on how Medicare determined split shared visits work had been put into a manual, but it had never gone through the notice and rulemaking process like it is right now for this 2023 proposed rule. So Medicare is now going through that regulatory process and giving us an opportunity to comment on it. So it's a good regulation. It's a good policy that has gone through the appropriate procedures. CMS defines a split and shared service between a non-physician practitioner and a physician, or even two physicians of the same specialty in the same group practice, and limits it to the facility setting. This is not a billing mechanism that is available in the office or the clinic setting. And Medicare's guideline says that the professional who rendered the substantive portion of the visit is the one that should report the service, because providers of the same specialty in the same group practice are considered the same provider for billing purposes, and only one provider per specialty per group practice gets to report an evaluation and management service per patient per day under Medicare rules. So that concept of substantive portion is what Medicare has been refining, and proposed that regardless of whether your level of service is selected based on the complexity of decision-making or the total duration of time, that you must choose the billing provider based on the one who rendered the greatest amount of time, the majority of the time, greater than 50%. So if we happen to have three Christie hospitalists who see the patient per day, unless one of them happens to have rendered greater than 50% of the total time among the three of them, it's possible none of them would meet the criteria to even be able to bill a visit. Medicare's delaying that implementation until January of 2024. So we've got an opportunity to continue to comment on how split and shared visits work operationally in your practices and in your organizations. So I'd encourage you to take a look at that and provide feedback to Medicare through the comment process if you have questions or concerns on how that would be implemented. So I mentioned observation codes go away. The concept of observation status, at least for purposes of selecting an evaluation and management code on the professional side, goes away 2023 for evaluation and management coding. What we today call inpatient hospital codes will just more generally be called hospital codes, without regard to whether the patient's technically an inpatient or an outpatient. We had codes for outpatient consultations. And whenever we have a patient who is in observation status, if we provide a consult to those patients, we will no longer use hospital consult codes, we will use the consult codes for office or other outpatient services. Now, Medicare doesn't pay for consultation codes, so that would apply to all other payers, most of the major commercial payers who still do recognize consultation codes for billing and payment. One of the things that will change that I encourage you to look at, if you have providers who are compensated based on work RVUs, or even for your own internal sort of pro forma and financial analysis, is that right now in 2022, the codes for for inpatient hospital services and their counterparts for observation hospital services have the same value for each level of service. We deleted, or will be deleting, all of the observation codes and just using this hospital category, what today we call inpatient hospital codes, beginning 2023. But Medicare and CPT, this is affecting all of your payers, is revaluing those codes that remain. And they're doing it in a way that I think could impact some of the initial hospital services values, and ultimately their payment will go down. So if you have any payers that are basing their rate of payment to you off of the work RVU value from Medicare, those are payer agreements you'll want to take a look at that will be impacted, as well as your physician compensation agreements if they are work RVU based and you have a lot of providers that are hospital practice based and see patients in the facility setting. With eliminating the concept of observation services, that means that observation discharge code 217 goes away. That code did not require identifying how much time was spent on the patient's discharge from observation care, because there was only one code. It's all the time that you spent with the patient on the day of discharge. The codes for inpatient hospital discharge, what will soon become just hospital discharge regardless of status, they are time-based. So providers who have been used to observation discharges need to know they need to start documenting the time that they spent for observation care on the day of discharge. Because if it reaches 30 minutes or more, we want to be able to capture the higher complexity, the higher revenue for that time. Otherwise, without time being documented, we have to assume it's 30 minutes or less, and that's going to be a lower paying service. Okay, I talked about remote patient monitoring and how we're going to report remote therapeutic monitoring in 2023. Medicare was concerned with this group of codes in the medicine category that were really designed to account for the work of physical therapists, occupational therapists, speech therapists who may be using monitoring, but who can't report codes from the evaluation and management section because of their scope of practice. But in those RTM codes, the way they are valued is that someone other than the professional billing for the service, clinical staff, is helping do the work. Medicare's concern was physical therapists, occupational therapists, speech therapists, who these codes were really designed for, do not have an incident to benefit under the Medicare program. So in order for Medicare to pay for their services, it has to be personally performed by those professionals and those disciplines. It cannot be delegated to other clinical staff. So Medicare would be creating 4 new G codes, would not pay for the RTM codes from, or at least certain ones from the code book, because these new G codes would identify whether the service was personally performed by the billing practitioner or performed by clinical staff. And if performed by clinical staff, only professionals who have an incident to benefit under the Medicare program, like physicians or nurse practitioners, would be eligible for payment for that group of codes. All right, so let's switch gears and talk about telehealth policy for a minute. with telehealth codes on the telehealth list, we now have kind of three, actually I'll say four buckets of the way codes can be covered as telehealth services by Medicare. We have what are called category 1 and category 2. Those are services that will be permanently covered as telehealth services. They resemble office or consult type visits, and Medicare evaluates every year whether services should be added to that permanent list. For next year, there's really only 3 codes that are going to be added as permanently covered telehealth services. And those are the prolonged service codes for hospital visits, the new G codes Medicare is creating, because Medicare already covered prolonged inpatient or observation hospital care codes. Some of those are being deleted. Medicare is creating these new G codes for prolonged services. So it's really just these new codes. It's not really a new service that's being added to the list. Medicare commented that none of the requests that they received by the February deadline met criteria to be added to the permanent telehealth list yet. So mark your calendars. February 10th is the deadline. If you have services that are temporarily covered right now, or maybe that aren't covered at all as telehealth services, but you want Medicare to consider them for coverage, this is when you need to go. I've got the link down here at the bottom to Medicare's website and submit your request. Having data on the service, the description of service, how you can meet the full code descriptor through an audio visual or audio only format, quality data, access data, all of that information with your submission is really going to increase the chances that it's considered to be added to the list of telehealth services. Medicare has made a comment for a few years now in the proposed fee schedule that they're not getting that data, that they may simply get a request saying, please add CPT 1, 2, 3 to the telehealth list. And that doesn't give Medicare enough data. They're not going to do the work to evaluate how it meets the criteria, and they need the requesters to help produce that information. So that's kind of the category 1, category 2. Those are the permanent telehealth services. The last 2 categories of covered telehealth services, I'm going to call temporary and category 3. So temporary codes were added as a result of the public health emergency and generally would go away the day that the public health emergency ends. We do have an extension that would allow those to continue to be covered for 151 days after the public health emergency ends. But essentially, those are gone after that time frame. Category 3 is a new bucket that Medicare created a year or so ago to take these temporary codes that would go away when the PHE ends, or 151 days after the PHE ends, and will allow them to continue to be covered through December 31st of 2023. Initially, when that was proposed, that seemed like a long time away, and that was going to give us a long extension to have these telehealth services covered after the PHE ends. And here we are getting ready to go into the 2023 year, where that doesn't seem like quite as much leeway as it did a year or so ago. But those in the category 3 bucket will continue to be covered even after 151 days after the PHE ends, assuming that's sometime in our relatively near future, through 12/21 of 23. And the goal is that would give providers and the community enough time to produce information to Medicare to show those services in category 3, how they meet criteria under category 1 or category 2 to be made permanently eligible. So I think of this group of codes as the ones that have a really good chance to become permanently eligible telehealth services. They just need providers to submit information by February 10th showing how you can meet the code requirements, how it's safe, effective, increases access, and give Medicare some data to help make those permanently covered. In the proposed rule, Medicare is taking some services from what we currently have in the temporary bucket that would go away 151 days after the PHE ends and moving them to the category 3 bucket so that they will be available theoretically longer until December 31st of 2023. So several therapy codes are already in that category 3 bucket, and Medicare is taking a few others that were not already there and making them category 3, continue to be available through December 31st of 2023, which in theory would be after the PHE ends. More codes that are not currently even on the telehealth list, but these are the codes that are being listed on the category 3 list. So this is kind of a list of those that would continue to be available through December 31st of 2023. I won't read all of those to you, but just so you've got a comprehensive list there. These are not permanent telehealth services. So if you are providing these in a, telehealth format, somehow I exited my, oh, come on. There it is. If you are providing these in a telehealth format, you want to try to, as best you can, I really encourage you to look at that submission deadline, February 10th, and provide Medicare with feedback on how you're delivering those services safely and effectively. A few more that have been added as temporary codes, not only that'll be covered as a result of the PHE, but are also automatically being moved over to category 3 and will continue to be available through December 31st of 2023 are listed here. Now, one thing got the equal sign with the line through it, if you remember from high school algebra, does not equal some temporary codes that describe audio only services are not being added as category 3, which means those will go away 151 days after the public health emergency ends. That's the time period that Medicare is mandated to continue covering audio only services. But at that time, the default definition of an interactive communication, a two-way real-time audio and visual service, will go back into effect. And so audio only services in general will no longer be covered as telehealth services. Okay, just another list of codes for you that will go away 151 days after the public health emergency ends. So these are the codes that are on the temporary list. All right, just a couple of updates on place of service and modifier reporting with respect to telehealth services in that category from the proposed rule. Prior to the PHE, we were reporting place of service 02, which describes a telehealth service. And when we use place of service 02, any codes that have a payment differential, depending on whether they were done in a non-facility setting, like an office, versus a facility setting, would be paid at the lower facility rate, with the idea that a lot of that overhead you have in the office setting would not apply to a telehealth service. So that modifier 02 signals to Medicare to pay the lower facility-based rate. During the PHE, we were instructed to use the place of service code that would describe where that service would have been provided if it were delivered in person, face-to-face, like place of service 11 for an office. I don't know, place of service, trying to think of the hospital setting codes, 22. We add modifier 95 to then indicate that it was a telehealth service. So 152 days after the public health emergency ends, we will revert to using place of service 02 and new place of service code 10 for telehealth services for Medicare. Some of your commercial payers may still be using place of service 02 and may start to be using place of service 10. New place of service 10 was created earlier this year, although Medicare has not been using it and does not plan to use it until 152 days after the public health emergency ends. Place of service 02 indicates that we have a telehealth service rendered to a patient in a setting other than the patient's home or residence. And then place of service 10 is a telehealth service rendered to a patient at their primary residence or at their home.
And Rochelle, we do have a question in the chat. For RPM, is there any hope of relief for the time requirements to more of a value or outcome based? It's difficult to capture due to multiple providers, multiple modes of communication, et cetera.
So absolutely understand the question for RPM and even RTM that are time-based codes for that monthly monitoring where we have to achieve 20 minutes of monitoring time throughout the month, and you may have multiple individuals involved in reviewing that monitoring. There is nothing in the CPT book for next year, or surprisingly, there's not a lot of guidance at all with respect to RPM or RTM and that those types of issues or clarifications in the proposed fee schedule for next year. I've got a long list of questions of the kind of gray areas that have been raised with RPM and RTM that I'm hoping to submit as comments and hope that Medicare will answer or clarify in the final rule. But other than creating this kind of new group of G codes for RTM to make them available for therapists, RPM and RTM were not widely discussed in this rule. And that was a surprise to me because I very much expected to see some more information on that. So I guess that's a long way of saying no changes to alleviate the burden on documenting the time for the monthly RTM and RPM at this time. We've got a modifier to indicate when our telehealth service was rendered using audio-only technology. And that modifier will become important even after the PHE ends, when audio-only services generally will no longer be covered, when we continue to use audio-only services for certain telehealth visits related to mental health services after the PHE ends. And those of you that are RHCs and FQHCs, currently using modifier FQ for that purpose, beginning next year, we're going to swap that out. You'll be using modifier 93 for that as well. Gosh darn it, I keep hitting the wrong button here. There we go. Okay, so this is important too, and I know we're getting close on time, and I've just got one or two more slides here, but this I think is really critical, and I'm hoping to provide comments to CMS on this as well. Remember that as we kind of got into the PHE and flexibilities early on in the process, Medicare clarified that telehealth can be rendered incident to the services of the primary professional, right? So your nurse who may do an in-person blood pressure check could do a telehealth visit incident to the services of the physician, and that could be billed under the name and number of the physician. Then we had clarification that because incident to requires direct supervision, which means nurse and physician need to be in the same office suite, so doctor is immediately available if needed during that telehealth session, that direct supervision could be accomplished through what's called virtual presence, immediately available to join the telehealth session. Because we've been doing this for several years now, many of you probably have developed models where you have more staff who are able to work kind of remotely, a work from home nursing position or physician position for that matter, to provide telehealth services to patients, and they're not in the office suite with the billing provider. And Medicare said a year or so ago in the Federal Register that there was nothing that had ever prevented that. But this concept of virtual presence was sort of a new definition, a new way to meet direct supervision to do that. In the proposed rule, Medicare said that after December 31st of the year when the PHE ends, we will revert back to the rules for direct supervision that were in effect prior to the PHE, which means in the same office suite and immediately available. So that idea of virtual presence, even for telehealth, would go away. That might impact some of our work models and folks who are working from home and rendering that service incident too. But as I first read that, it doesn't completely eliminate the ability of the nursing staff or other auxiliary personnel to render a telehealth visit incident too. But Medicare continued and said, and I'm going to put this in quotes, telehealth services can no longer be performed by clinical staff incident to. And I'll just add, this is my personal comment, my personal interpretation. This is not necessarily on behalf of HTRC, but that's not what that should mean. Even if we eliminate the concept of virtual presence, we could still meet direct supervision by having the personnel in the office suite immediately available, where the physician or the billing provider is located. So the way Medicare wrote this was the concept of incident to goes away. We can no longer have clinical staff rendering a telehealth service. It's got to be the actual billing provider personally rendering that service. So I'm hoping that we see some clarification on that when we get to the final rule here in a couple of months. Very quickly, because I know we're right at the top of the hour, RHCs, FQHCs, there's going to be increased coverage and separate payment on top of your all-inclusive rate or your per visit rate for chronic pain management and treatment services. So if you're doing that as an RHC or FQHC, you want to take a look at that. It looks and feels a lot like chronic care management that you can bill on top of and separately from your base rate. So I'll pause there. If there's any questions in the chat, I'm happy to help answer those.
We do have one. I know it's at a little bit after 1, so if people need to hop off, that's totally fine. We had a question about from Christina saying we had a memo stating place of service 10 was to be used if patients were seen in their private home.
That's right. So that it's been very confusing because CMS is the owner of the place of service code set. So CMS, because of requests from private payers, commercial payers that were indicating they had a need to differentiate between telehealth services rendered in, healthcare settings versus patients at home, asked CMS, the owner of the place of service list, to add that distinction. So CMS adds place of service 10, but Medicare, as a payment program, indicated they didn't have a need or a means to use it yet and were not requiring place of service 10. Under this proposed rule, 152 days after the PHE ends, Medicare will begin using place of service 10 for telehealth services rendered to a patient who is at home or in their private residence. But also remember, 152 days after the PHE ends, our old definition of eligible originating sites will go back into effect, and with very limited exception, does not include the patient's home. So we will only be using that place of service 10 for those services like substance use disorder, certain home dialysis, and certain mental and other behavioral health conditions that have a carve out to that originating site requirement 152 days after the PHE ends. Clear as mud, right? Well, thank you. I know that's a lot to digest. As quickly as I can try to digest and share 2,000 pages of information, but certainly you take this away and you think of any questions afterwards that I can help answer on that proposed fee schedule, I'm happy to do that.